It is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. That was the tremendous Eagles again. Probably the third time I played the song this year. I really love it. This is Dr. Minarcik, and it's Tuesday. We're in Chicago. It's about 9 in the morning, and today is April 23rd, 2013. And this is our 62nd session and final technical session of our free Global Online Medical School Pathology course. I guess one of the second biggest word on my cheat sheet today is final. It would not be fair if I did not tell you my feelings about the final session. Well, like all of the years we've been doing this is the end of our 4th year. It's been unbelievable fun and unbelievable enjoyment for me, and unbelievable feeling that I've done something good. I guess because I work pretty hard, I should feel really good, you know, like 3rd graders at the last day of school, just running out and getting a feeling that's beyond description. But I must tell you, I'm feeling very sad too, because basically for the next 3 months I won't have a life except for maybe to have fun, go hiking, visit people, take trips, chill out, so I'm really very, very sad too. Welcome to Earth Day. Yesterday was Earth Day. That's why we have this big blue marble on our screen here. And I also want to tell you that Dr. August is here today. Welcome back, Dr. Deborah August. The buzzards and buzzardesses have missed you. So once again, if I'm saying something in pediatric pathology that you want clarified, just type it in. And I think Dr. August probably has boned up on her pediatric path a little bit. She'll try to help you as much as she can, just like I would if I wasn't yakking as well. The big announcement for today is, even though this is our last technical session, we will have one more graduation ceremony. I don't think it'll be long. I don't think it'll be 2 hours, but we'll have all the people here that made this course possible. We'll have Dr. Liu here. We'll have Dr. Waringi here. I'm hoping that Dr. August will plug in her microphone and say a few words as well to our graduation buzzard class of 2013. All of the sessions that we've done this year, this is our 62nd, all of them are free. You could use them in any way you want. A lot of people try to sell these things. I've noticed online people try to sell my course, and I don't know what I have to say about that. I guess I don't care. I think it's funny. It might be sad that there are some people who would actually pay for this course from somebody else without my permission, when they all know they could get it free just by going to my website, medicalschoolpathology.com. Yes, I'm on camera now. That's why I combed my hair and shaved today. But I will go off right now, and we'll do our test and talk to the buzzards a little bit, and then we'll start our material for today. Well, the first buzzard question is, and I hope you get it right, is, can you hear me well? And I'm seeing all the yeses. Somebody said, you should keep the camera on the whole time. Yeah, that's if you want to see ugliness for 2 hours. Second question is, what do you see on your screen? Okay, you see the big ball. Okay, and of course, I'm interested in the quality of the sound too. Did the music from the Eagles sound very good? Did it sound almost like your CD player was on? Okay, good. The last thing I wanted to say is that the music that we'll have during the break will be all sacred music from the big religious, cultural parts of the world. We're going to have something from Islam. We're going to have something from Hinduism. We're going to have something from Christianity. And we did this once before, but I went out to some of our buzzards and I asked them to help me find classical, sacred, religious music from their cultures. And we got the top 3 today. So that will be during the break. But before we take the break, let's actually do some work. So that's why I'm popping up the window here. And if you remember, in our last episode, our cliffhanger, we talked about the what was used to be called hyaline membrane disease. Now it's called RDS for respiratory distress syndrome. And of course, that's of the premature. There's an adult one that has an A in front of it. We talked a little bit about treatments, and we said that there are all kinds of things that can be done. Now, one of the main things, of course, is to give the baby oxygen. Now, it is as great as oxygen is to us, we all need it. We all need it more acutely than water or anything else. Oxygen does have its complications. It does have its toxicity. Now, in the older days, we called eye damage due to oxygen toxicity. We called it retrolental fibroplasia. You still see that term, but now the literature is kind of flooded with a new acronym called ROP for retinopathy of prematurity. And of course, the prematurity indicates that the babies who get oxygen, or perhaps excessive oxygen to the point where it may hurt their retinas, are generally premature because respiratory distress is related to prematurity. So, oxygen can potentially damage the retina. Okay, here's a retina. I did not get permission from my son to show this, but as you can see, there's a zone at the edge of the vascularity in which you see an increased number of twisted vessels and kind of like a zone. And they talk about generally zones of damage with retinopathy of prematurity. And the principle is this. Let's make this very simple, okay? Now, you know from what we talked about before in your physiology that hypoxia in itself, or lack of oxygen, stimulates VEGF, vascular endothelial growth factor. In other words, an agent which will normally develop the blood vessels of the retina. By the addition of oxygen, this interferes with VEGF. Let's just keep it at that and not go into anything more complicated. The oxygen therapy then suppresses VEGF, causes endothelial apoptosis, and the fact that these blood vessels cannot develop normally may result in hemorrhages as well. Another concept which is related to oxygen, but it's also related to the mechanical process of ventilation itself, is the term bronchopulmonary dysplasia. Now, remember we said in kids the word dysplasia does not refer to pre-malignancy. It refers to the fact that cells in tissues are not normally placed where they should be. In other words, they're disorganized or dysplastic. Now, it is a well-known fact that oxygen suppresses lung septation, okay? Septation is the growth of the bronchopulmonary tree and differentiation into the saccular alveoli, okay? Well, not only does oxygen interfere with that, but so does the mechanical ventilation as well. So in the older days, not so much now, we used to see more bronchopulmonary dysplasia with respiratory distress in newborns, seeing things like squamous metaplasia, fibrosis, and so forth. But remember, despite the mechanical ventilatory process causing this, also the fact that hyperoxygenated lungs in newborns will also be a big factor as well. Let's move from the eye now into a newborn. In fact, let's move from the lungs in general down to the GI system. There is a very common, well, I said common, but once again, like RDS, the commonness of it approaches prematurity. So just like we said, RDS is related to prematurity, so is necrotizing enterocolitis, okay? So the more premature you are, the more likely you'll have it. With severe prematurity, it can have as much as a 10% incidence. That's very common. There's a couple thousand cases every year in the United States, and you know, there's no reason for me to go and waste your and my time into all kinds of theories, but we have an enterocolitis, an inflammation, a hemorrhage, a bacterial infectious process, either primarily or secondarily. What are the factors? Well, one factor is intestinal ischemia. Generally, it's not really understood what causes it. There's no one single thing that we can say causes it. But you have breakdown of mucosal barrier, you have secondary bacterial, especially gas-forming bacterial infections. You'll actually see air bubbles in the submucosa, both radiologically as pathologically. And of course, not enough blood supply. So these are all the factors. What the ultimate cause is, if there is one, is not really understood. And here's a nice picture. Here is a baby with a colon full of air. Actually, this may be small bowel because I could see it's very, very well. But when we say enterocolitis, we're talking about both small and large bowel. Okay, you could see the hemorrhage along the mucosa. I wish I could tell you that you could see the inflammation, but it would be almost unheard of to think of this ulceration and hemorrhage and mucosal breakdown as not having a secondary inflammatory component as well. And hey, here's something interesting. Take a look at these arrows. You know, you could see an arrow here, you could see an arrow here. What is the arrow pointing to? It's pointing to a little circular thing where if you were not so concerned with proper terminology, you'd probably call it like a little bubble. And that's due to the fact that secondarily, the bacteria which are then invading this colon, in which there has been ischemia and mucosal breakdown, are now forming gas. This is called pneumatosis intestinalis, and it could be even seen radiologically as well. I think I threw an x-ray on here, and you can see, of course, air within the colon. That's a normal finding. But what about these smaller air bubbles? You know, they shouldn't be little spongy bubbles within the wall, and they're primarily in the submucosa, and this is due to the fact that the secondary bacterial invaders are now creating gas as well. Okay, let's talk about another concept, hydrops fetalis. Don't let it spook you out. All it means is exactly what it says. Hydrops means water, and fetalis means fetal. Okay, these are edematous fetuses. Well, the reasons why fetuses might be significantly edematous is the same reason why big people would be edematous, and that's generally underlying problem is heart failure. It's more likely to be a high output heart failure, but it can also be a congenital heart defect causing low output heart failure as well. Now, we've already mentioned with Turner's syndrome, XO, that the patients frequently, severe patients, would have cystic hygromas. Okay, now you may think that a cystic hygroma, because of its terminology, is a tumor, but actually it's more of a water collection, especially in the neck region. And of course, if you want to think of that as filling up the lymphatic spaces, and if you want to think of this as a type of lymphangioma because of dilated water spaces within the lymphatics, you can. But cystic hygromas are basically collections of the water in the neck, which you can see with hydrops fetalis, and specifically described in a classic chromosome abnormality, XO. Now, the more likely way for a fetus to be born, probably not alive, but sometimes alive, with hydrops fetalis, is to have a heart failure. We've already gone into the mechanism with edema and heart failure. Now, why would a person born have a high output heart failure? Well, the most likely reason is that they have had an intrauterine hemolytic anemia, and on the basis of being severely anemic, that heart tries to work overtime to deliver oxygen to tissues to the point where it fails. It just can't do it anymore. The anemia is so severe. So when we see RH incompatibilities, and even things like thalassemias, we mentioned hydrops with severe thalassemia majors. It can also be present in a viral infection we talked about in newborns called B19. It could be present in twin-to-twin in utero transfusions as a high output failure. But think about it, if the patient or the baby is also born with a congenital heart defect to the point where the heart just can't deliver the blood and fulfill Starling's laws, even prenatal, then the edema could be on the basis of a low output failure as well. Here's a picture of a typical hydrops. You could see in the severe forms, the edema loves to accumulate in the neck region. That's why the term cystic hygromas were started. And of course, you could think of this as a tumor of the lymphatics, but it really isn't. It's just excessive collection of fluid. The whole baby is just completely edematous, and that's not terribly hard to understand if there's been a high output heart failure or a low output heart failure. And in this case, it just happens to be associated with Turner syndrome. Now, the most common reason for a hydrops is what we would call an immune hydrops. I'm going to go over it very quickly. You may have heard of it already. And then we'll go into it in more detail a little bit later, because the concept is very important. Let's say that the fetus inherits an antigen from the father. Like if you remember, the Rh system is called CDE, if you want to break it down into 3 different alleles. Well, the big D, or the Rh big D antigen, is what determines your Rh positivity. So you got a baby that inherited the big D from the father, but the mother doesn't have it, okay? That means if the mother is exposed to the RD antigen, she might start to make antibodies against it. And if she's exposed, like in the first pregnancy, she may not have a big response to it, but she may be sensitized. So on subsequent pregnancies, she may have enough of a sensitized IgG buildup to actually destroy those cells, okay? And if they're being destroyed, you can have a high output congestive heart failure. You could have, remember when you have a very, very big hemolytic anemia, you can have erythroid hyperplasia that may extend it to things like liver and spleen. Okay, now normally when a baby is born, there still may be some residuum of hematopoiesis or erythropoiesis going on in the liver, which should quickly disappear. But in a hydrops baby, they have an abundant amount of erythropoiesis, okay, as well as mostly hemolytic anemia, erythroid hyperplasia going on in their liver as well, which persists, okay? So in most cases, this is due to the Rh antigen. Rh positive babies getting the big D from the father, the mother having the antibodies after they're sensitized to the big D. That's the pathogenesis. Okay, so you know when babies are born, there is a breach of the maternal fetal circulation. Some of those babies' blood cells leak out into the mother. If this is her first pregnancy or first time that there has been some entrance of fetal cells into her blood, she's going to start making the antibodies. And of course, with subsequent pregnancies, it may be enough to cause hydrops and hemolytic anemia. You know, that really doesn't happen too much anymore. Babies are tested, mothers are tested. And of course, RhoGAM, which I'm sure you all heard of, is a compound which has anti-D IgG antibodies, and it coats the fetal cells, okay? So they don't sensitize the maternal antibodies, okay? So RhoGAM has basically all but cured this disease or prevented it, and it's done. It's being used all the time. Okay, I don't know if I could say other countries, but certain in this country it is. So what happens when you have a baby born with hydrops? Okay, well, the first thing is to prevent it by perhaps doing a chorionic villi sampling, amniocentesis. It's very easy now to take, little parts of the placenta, which is the baby's a DNA, and do a blood typing or amniocentesis, getting some fetal cells. Okay, you can even do fetal transfusions in the umbilical cord. Okay, and of course, you might want to deliver that baby as early as possible. Remember, with RDS, you might want to delay that delivery as much as possible, but in this, you want to deliver it as early as possible to prevent further attack of the baby cells by the maternal antibodies. Of course, once that baby is born, you may have to result in exchange transfusions, basically giving that baby a whole new bunch of cells, which will result in a non or not a hemolytic reaction, okay? Because you'll be monitoring that transfusion and the consequences of it by just looking at the baby's hemoglobin level and bilirubin level, because the more bilirubin, the more unconjugated bilirubin, the more hemolysis is going on. Okay, here's a fetal liver. And I think you could probably believe right away that this is a liver. And you could see a peppering of cells. Oh, I really don't think you could identify these cells. You could say they're small. They have not much cytoplasm. They have pretty dark nuclei. They're generally smaller than these hepatocytes that you see around here. This is extramedullary or fetal hematopoiesis. And I'll admit, when you just look at that, you might say, well, could that be a hepatitis or something like that? Could that be CMV and lymphocytes? It could, but when you look carefully, you could see that these are hematopoietic cells. And it's only one screen capture, but a lot of times when you see little foci of cells in the liver, once you find the megakaryocyte, you know that this is not an inflammatory disease, but this is extramedullary hematopoiesis or blood formation going on in the liver. Of course, in the newborn baby, once that bone marrow becomes available, which is soon after birth, this extramedullary generally disappears. Kernicterus is a term that describes the staining of white matter in the brain by unconjugated fetal bilirubin. Okay, now you know that in the breakdown of blood cells and hemoglobin, that the various bilirubin compounds are developed. And of course, bilirubin itself is not really water soluble. It doesn't get to be water soluble until it's conjugated by the liver. So if there is an excess of unconjugated bilirubin, this implies a hemolytic process. And because the white matter of the brain, particularly the basal ganglia, which you could see here, and maybe to a lesser extent the thalamus, okay, this is called kernicterus. Icterus means jaundice, and I was trying like crazy to get the root word for kern, and it really doesn't make sense. So you just have to remember kernicterus is a bilirubin of the white matter of the brain, particularly basal ganglia and thalamus. Here's a little more scientific, perhaps repetitive thing of what we just said. We said that in a Rh negative mother and an Rh positive fetus with fetus blood cells, you get cross-placental transfer of these blood cells, sensitizing the mother. Okay, as a result of that, there is a erythrocyte antibody complex resulting in excessive breakdown of those cells, in other words, anemia. And as a result, the baby's EPO kicks in to produce or try to produce more red blood cells, not only by increasing the production in the bone marrow, but expanding it to other areas. In this case, we saw the example of the liver, a spleen. Lymph nodes technically are possible as well. If the anemia cannot be corrected, we then have a cardiac decompensation, high output heart failure, and edema on the basis of that heart failure. Okay, hemoglobin breaks down to bilirubin. The bilirubin then creates a jaundice, and because it's a unconjugated or pre-conjugated bilirubin, you now have staining of fatty tissues like white matter of the brain. Okay, that's the whole concept again. And let's get into, we've been talking a lot about neonatal problems and chromosome defects and respiratory, hematologic problems. Let's talk about the most common classical specific genetic errors of metabolism. Now there's a whole bunch of them. If you remember, we talked about diseases of genetic diseases. We gave you a whole big list of basically autosomal recessive inborn errors of metabolism, lysosomal storage diseases, inability for enzymes to metabolize certain things because the enzymes are not there because of mutations. But let's talk about the big ones. Let's go up to the three common ones. And the first two are very much have a similar story because it's a result of a very simple lack of an enzyme to process a substrate, and therefore buildup of that substrate causes a disease. Then we'll spend more time talking about cystic fibrosis, which is the genetics behind cystic fibrosis is so complicated. I'll be very honest with you, I don't understand them. But let's talk about all three of them. Here's PKU. Take a look at that Coke can that's in front of you right now. Of course, if you were in class, you might not be allowed to have the Coke can. But take a look at it. There's probably some statement there about whether it's safe for PKUs or not. PKU means phenylketonuria. Phenylketonuria, PKU. It's a disease due to a lack of an enzyme of phenylalanine hydroxylase. In other words, you have phenylalanine, and the hydroxylase enzyme would normally oxidize that, okay, metabolize it. But what if you don't have that enzyme because the gene that codes for that enzyme is not present? And it's an autosomal recessive disease, like all three of these diseases are. They're all autosomal recessive, which means they follow the typical pedigree. They appear early in life. There's full penetrance. There's instant recognition, big severity. There's not much in terms of variation to it, with the exception of that being cystic fibrosis. There's a lot of variation. But let's get back to the concept here. You don't have the gene because of an autosomal recessive disorder. Very common in Scandinavian people, very uncommon in African American and Jewish people. You don't have the enzyme, so the phenylketone or phenylalanine builds up, okay, builds up to dangerous levels, accumulates in the brain. So all of the pathology that we talk about this, doesn't mean much, because if you're going to be looking at this from a point of view of a step one question, they're not going to give you this stuff. They're going to say a baby is normal at birth, but after weeks, the mother noticed progressive impairment of cognitive function, brain damage, in other words, mental retardation, which is not present at birth. That's the key for it clinically. Because the phenylalanine can't be broken down, you might get other metabolites in the urine. And of course, the big one is phenylketone. So that's why it's called phenylketone in the urine. There's really no treatment. You can't give the baby the gene or the enzyme, but what you can do is restrict that baby's phenylalanine, okay? Theoretically, forever. That's why when you buy foods in the store now, you look at the little label, and if it says that it's okay for PKU, then you could buy it, okay? And there's various forms of the disease, but basically it's still autosomal recessive, appearing early at birth, full penetrance, full expression. I think you could probably draw the same general conclusion for another autosomal recessive inborn error of metabolism called galactosemia. If you remember from your biochem, the milk sugar, lactose, is broken down into glucose and galactose. Now your body loves the glucose, it could use it, but the galactose has to be changed back into glucose for your body to utilize it. Well, the enzyme that starts that transformation process is called GALT. And the reason why I called it GALT is because I could never remember glucose 1-phosphate uridyl transferase. That's why it's called GALT. It's needed to transform that galactose back into glucose, but if you have a autosomal recessive problem in which you don't have GALT at all, your galactose then builds up. Okay, and like PKU, of course the brain is possible, But the difference in terms of organ damage, PKU, the primary clinical presentation is brain. With galactosemia, you see a lot of fatty change in the liver. You see cataracts in the eye. So it's almost like a cirrhosis because it's preceded by a lot of fat, and they may progress to fibrosis leading to cirrhosis. So that's the CCPP, or classical clinical patient presentation for galactosemia. Okay, well, it's easy to diagnose because you look for reducing sugars in the urine. It's in the urine because it can't be metabolized into glucose. And treatment, of course, is exactly the same as the treatment for PKU, and that's just restrict it. Now, I don't know why it says the first 2 years of life. I don't know if that implies better handling of this because the gene will still never be present, but they say that the restriction is best for the 2 years of life because that's when the most organ damage is going to occur. Okay, let's talk about our third and final common inborn error of metabolism, big disease, number one genetic killer of Caucasian people, cystic fibrosis. I don't want to talk about the genes because it's a wide mutational spectra, okay? There's a lot of things in the environment that can modify it, but the general morphology we'll be looking at and the clinical course. And I'm going to try to make this as simple as possible. I've been to several talks on cystic fibrosis, and I always come out saying, why are they confusing us? So I tried to make this simple as possible. Another name for cystic fibrosis, and maybe even a better name, is called mucoviscidosis. That means your mucin, your mucus that's produced in many areas, is viscid. It's more thick than it should be. And technically, that thickness will then block the mucus passageway, result in inflammation, and perhaps even dilate the duct, so-called cystic fibrosis. So if you really remember that they both describe the same thing, you can understand the basic range of pathogenesis and pathology. Also autosomal recessive. It's the most common lethal gene disease affecting Caucasians. Okay, and even 1 out of 3,000 babies have it. And if you do the math, and if you see that about 2 or 4, 3% of the population of Caucasians are carriers, you say, well, what's the chance of 2 of those getting together and producing a baby, blah, blah, blah. You could do the math, and you could see from simple Mendelian laws, it's about 1 in 3,000 babies are born, okay? It's not common in Asians. It's not common in African Americans. This is basically a Caucasian disease. And let's make this very simple, okay? The ultimate expression, the ultimate phenotypic, physiologic expression of this disease is that chloride cannot move in and out of the cell. Now, there's 2 different types of cells, the way they handle it, but let's say this again. Don't be confused. In cystic fibrosis, you have problem moving chloride in and out of the cell. Okay, now you're probably asking yourself, why should there be abnormal viscid mucus secretions, or why should there be increased chlorides in the sweat? Because you've already known that the sweat chloride test is a measure of sweat chlorides, and why should they be increased? Well, because in the case of the sweat glands, the chloride can't come in, okay? In the case of other mucus secreting cells, the chloride can't get out, so the sodium has a mechanism for coming in, and this mucus is now thicker. Here's the general diagram. You see this red thing here? This red thing is a protein, okay? It's called CFTR. It's the thing in red. It's the squiggly thing on the cell membrane. It's called the cystic fibrosis transmembrane regulator. But if you're really cool, everybody calls it the CFTR. It's the one in red. Well, there's two reasons why people have cystic fibrosis. In one case, the CFTR never gets to the membrane. Okay? In another case, it gets to the membrane, but it doesn't work. So these are the two possibilities for cystic fibrosis. Okay, the CFTR gene is the thing that makes the CFTR. Okay? Now, normally, if you have a CFTR gene, it lets chloride in and out of the cell. Okay? Now, in some cells, that also is associated with sodium going in and out of the cell as well. In some cells, it doesn't. So let's talk about what happens when the CFTR gene is mutated, not absent, doesn't work, and either it never gets to the surface or it gets to the surface, but it doesn't work. Well, in the case of a sweat gland now, remember, in cystic fibrosis, the pathology of the sweat gland is generally a little different from the pathology of all the other glands, like respiratory, intestinal epithelium, things that in which mucus is involved, okay? In normal sweat glands, you don't secrete mucus. But in a sweat gland with cystic fibrosis, it decreases your luminal chloride reabsorption. That means the chloride can't get in, right? That means you have more chloride on the outside, and because the chloride stays with the sodium, it means you have increased chlorides. That's why there's the common test, there's genetic tests, but the common test for cystic fibrosis is to measure chloride by inducing a mild electric current in the skin and then looking at the amount of chloride in there. Well, the sweat is then hypertonic, isn't it? Because the chloride can't get in. And there's another channel called ENaC, which is involved. So sodium can't really be reabsorbed too well either. So you have hypertonic sweat in cystic fibrosis. Now, in other types of cells, which are non-sweat cells, like respiratory epithelium producing mucus, intestinal epithelium mucus, in this case, you can't get the chloride out, okay? And because you can't get the chloride out, it inhibits the sodium channel as well. So that means that because there's not enough sodium chloride in the mucus secretion, there's not enough water. Remember, water follows the sodium. And therefore, the secretions are isotonic, but they're decreased in water. You have thick mucus. You have mucoviscidosis, or viscid mucus. That mucus blocks those ducts, and you remember anytime a duct is blocked, it could set up a cause for inflammation, fibrosis, and if you got a plug inside of a duct, it can become cystic as well, can't it? So that's how the name cystic fibrosis came about. Here's another diagram just showing the difference between the sweat cells and the so-called mucus cells. We said that in the sweat cells, the chloride, here's a normal chloride going in, sodium got it going in. In cystic fibrosis, the chloride can't come in, so there's more chlorides in the sweat, more salt, more electrical conductance, more chlorides because the chloride can't come in. Now, in cells that produce mucin, like airway cells or pancreas cells, for example, the chloride can't come out. And because the chloride can't come out, it affects the sodium channel, where the sodium now comes in at an increased rate, and with the sodium comes the water. And now the mucus is now thick. It's viscid, isn't it? And that thick mucus blocks ducts, causes inflammation in the lungs, in the pancreas, in every part of the body that's tubular and makes mucin, okay? Now, I basically wish this slide wasn't here, but I have to tell you, there's a lot, the genetics, the mutational spectrum between, resulting in CFTR abnormalities is very, very big. There's a whole bunch of different classes. They can go from mild to severe. And even though it is a generally autosomal recessive disease, and as you know, autosomal recessive disease should have full penetrance and not much variation in phenotypic expression. There's a lot of it because the complex genetics come into play. And let's just say, well, I'm not going to try to pretend like I can explain it to you because I'll admit I really don't understand it. I've tried several times. I'm sorry, I'm just not smart enough. Here's some of the spectrum of clinical expression of the disease. Okay, theoretically, somebody that has a negative sweat chloride test, or in other words, a normal level of chlorides in the sweat, might be at the very best possible scenario, a normal person, a normal female. If it's a male, the most likely thing he's going to have is azoospermia, might have an absent vas deferens, remember? The vas deferens is lined by these epithelial cells as well, okay? In the larger expression of disease, with this complex genetics, sinusitis might be present. We already said that azoospermia can be because of an absent vas deferens, a blacked, a fibrosed, okay? Earlier stage, lung disease, pancreatic diseases, perhaps mild. The lung disease can get worse with additional blocking and infection, inflammation of lungs and pancreas. It could get worse. Here we have now blockage of meconium, because that's very, very thick as well. You know, you can have a meconium plug. Babies with meconium plugs are instantly, automatically thought of as being possibly having cystic fibrosis. They're immediately tested. They can do the common test. They can do genetic tests. Of course, I think still the most common test is to put a little watch on the arm and look at the sweat chlorides after they've given them a little bit of pilocarpine, which induce sweating. In the old days, they would put them in a chamber and cook them, and when they would start to sweat, then they would start measuring the conductance and chlorides in a blotted paper that goes there. And of course, the most positive person with sweat chlorides, the most increased chlorides, will result as the classical, bronchiectasis, pancreatic insufficiency, also ducts being blocked in the liver, so cirrhosis. This is a very serious disease, and it still has a pretty high mortality. Not many people live beyond their 20s and 30s. I think the 50% mortality rate is somewhere still like in the 20s. And the positivity of the sweat chloride test is 100% related to the phenotypic damage to the CFTR. Let's talk about other organs. If we didn't say that already, plugging of ducts with vis mucin material, that could be genitalia, that could ducts of vas deferens, it could be the liver. Remember, you have bile canaliculi. It could be the pancreas. The islets are not affected because they are not exocrine. Okay, and of course the sweat glands. Now the sweat glands usually have a normal histology, but the sweat is hypertonic, hyperchloritic, hyperconductive. If I told you this was a pancreas, you probably wouldn't believe me. You'd probably say, oh, this is probably some lady with, fibrocystic disease of the breast, because there's really not much there except fibrous tissue. See those dilated ducts? They're filled with mucus, aren't they? Thick, mucinous material. You shouldn't see that. As a result, these ducts are being blocked. As a result of blocked ducts, you're having secondary inflammation. And as a result of that, you're having a lot of fibrosis as well. I wish I could tell you that this was an islet for sure, or maybe this was, or this was. I don't think it's high enough power where I would say that with certainty, but the islets in cystic fibrosis are normal. They don't involve ductular drainage, do they? You remember what this guy is? It's a normal pancreas. Look how much fibrous tissue is there in a normal pancreas? Not much. How much ductal dilatation is there? None. And by the way, here's a little part of an islet over here. You see that? By the way, I'm kind of asking you the question now because I'm curious. Can you tell this little group of cells here is an islet? Just say yes or no. Or yeah, you most of you are suspecting it, so am I. But except I know it because I'm a little more experienced. See? Cystic fibrosis. There's the cysts. There's the fibrosis. And here's the pancreas without cystic fibrosis. Of course, the lungs are usually the things that kill you. Lung infections, lung failure, secondary lung infection. I think we told you at an earlier time or somewhere that Pseudomonas was like #1, but here they have Staph aureus high on the list too. You know, Pseudomonas has a distinctive greenish appearance and even an odor to it. Staph aureus is regular old pus. Haemophilus, especially in the younger children, Haemophilus is like #1 cause of pneumonia anyway in kids under 2. Destruction of the bronchi because of the inflammation and plugged bronchi. Dilatation of the bronchial lumen, that's part of bronchiectasis, and scarring and inflammation of the bronchial wall. Here's another little diagram showing you all of the parts of the body that can be affected. Even though the sweat glands are not histologically changed, you know what the problem is there. You know the sweat can't go in. And most of these other organs which have a component for producing secretions in which mucin is a part, you now have plugging, obstruction, infection, fibrosis, dilatation of ducts. Now, in all honesty, I don't know why the ovary and cervix are there. I know the cervix has a lot of mucus glands. I don't understand ovary. I probably should have looked that up last night, but I forgot. So if anybody knows why the ovary is involved, you know, feel free to speak up. Diagnosis, of course, are the things that we talked about. Sinusitis in kids, gastrointestinal obstruction, pancreatic insufficiency, you know, salt loss, or really the ability of salt to, you know, to come in. In males, absence of a male vas deferens, no sperm, okay? This diagnosis is not always made at infancy. It could be made in teenage years or later. Of course, the common test, I would like to think it's probably still the single most common screening test, the sweat chloride test. Of course, if that's borderline or if the facilities are available, you could do the more detailed specific DNA analysis with gene sequencing and even look at several of those genes and make a more educated guess as to what the severity and the outcome of the disease will be. You can also do a nasal transeptal potential difference as well. But the regular old wristband or electrodes on the arm, the sweat chlorides, is still the #1 thing. Oh, here we go. The median life expectancy is still 30 years, so if you have cystic fibrosis and you make it beyond 30, you're luckier than half of everybody else. A good number of these are diagnosed as adults, most of them in infancy, because of these various symptoms and tests. And of course, one thing you could do is try to clear those pulmonary secretions as much as possible, treat the pulmonary infections. It's also one of the top reasons for a lung transplantation as well as a liver or pancreas transplantation. Okay, we're done with cystic fibrosis. Let's look at the clock. Let me think. Should we take our break now? It's 9:50. Let's do a vote. You want to take the break now, or you want to talk about SIDS? The first answer will do. The answer is SIDS. Okay. Somebody says break. Somebody said SIDS. Let's do the tiebreaker. What's the third person going to say? Come on. Okay. you're outvoted. We're going to talk about SIDS. It's really not a terribly difficult disease to understand because it's not really a disease. It's really the exclusion of other diseases. So, yeah, it has epidemiology, risk factors, statistical things it's associated with. It has some morphology, but remember, if it had a specific diagnostic morphology, it wouldn't be called SIDS because then it would not be a mystery anymore, okay? And of course, we have pathogenesis, and these are generally theoretical because still, I'll tell you, I've been to a lot of talks on SIDS, and in every single one I've been to, it's always been a rule-out situation, and it's been a case where there still is nothing specific found. Yeah, people can do some little studies and look at some of the neurons and the cardiorespiratory or the central nervous system area for temperature regulation, perhaps find a few abnormalities. SIDS is a diagnosis of exclusion. Okay, here's the definition. It's always in the first year. Okay, if it's beyond the first year, it may not be called SIDS. It's a baby that dies unexplained, mysteriously, usually found dead in the crib. A complete autopsy is done. You know, the police will come over and probably question the parents for 6 weeks and lock them up in a cell. And not only do they have like horrible, horrible feelings that their baby died, but now the police treat them like they murdered them. This happens all the time with SIDS. It's a horror upon horror. And it's the leading cause of death, if you remember from our original thing, of babies between 1 month and 1 year. And even though it has a certain incidence of, you know, about 3,000, okay, it's come down from 5,000, mostly because of better knowledge of the statistical factors that are related to it. But most of those deaths are in the earlier part. The closer you are to birth, the more likely you are to have SIDS. So most of the babies die in the first couple months, although they'll extend it up to 12 months. A baby dies unexpectedly first year after a thorough history, and the police have determined the parents didn't kill him. It's called SIDS. So these are statistically risk factors. They're not causes, but a lot of stuff has been done on this because it's a #1 cause of crib babies. These are mostly statistical, okay? Sometimes a group of statistics can help us to understand more etiologic, but these are statistical. Generally speaking, the mothers are younger. There's a greater connection with smoking during pregnancy and drug abuse. It may be a mother that had multiple kids at very short gestational levels. There may have been no or very little or late prenatal care. Generally more common in low socioeconomic groups. We all know it's more common in African American and American Indian than our Caucasians who got cystic fibrosis. Okay. Now, in the infant's point of view, it's more likely to be in males than in females, a little bit. That's a statistical fact. It's more likely to be in a product of a multiple birth, twin, okay? And if a prior sibling has died of SIDS, that also puts the other sibling at risk. Okay, they may have had more respiratory infections. These are statistical. They may have been, it's related to prematurity, low birth weight. And in the environment, more babies are found dead with SIDS sleeping in the prone position rather than supine. They're more likely to have slept on a soft surface. They're more likely to have been hyperthermic or perhaps loss of some ability, which infants normally have to regulate their body temperature. And of course, that's even worse with prematurity. And another nice study is that there's been a lot of smoking in the mother or father. These are all statistical risk factors, okay? So you're looking at all of these risk factors and you have a brain and you say, what does all this mean? And there's a lot of things that you could say. And remember, the parents of babies who die of SIDS are devastated for the rest of their life, okay? So generally speaking, the literature is not going to emphasize the uh, the kind literature, okay? The humane literature is not going to try to blame it on the parents or on their low socioeconomic things. Some studies have shown a few little problems in the cardiorespiratory control center. That's really not been proven to be a cause because remember, it's a diagnosis of exclusion. And of course, these environmental factors are things that are well-known risk factors. They can be controlled, and it's probably the main reason why the incidence of SIDS has gone down 50% in the last 20 years or so. And remember, it's a diagnosis of exclusion. These babies go to autopsy. I did a bunch of them, and we never find anything. We could say, well, there's been some multiple petechia, we've been some pulmonary congestion, but aren't these found in practically all people that have died, rather acutely? Little hemorrhages, that's very common. Pulmonary edema and congestion, the heart stops suddenly. Okay. They're not really evidence for what causes the disease. Some people have found some very subtle changes in brainstem neurons, perhaps those involved in respiratory or temperature control areas. But you really can't diagnose SIDS with certainty unless it's a negative autopsy. So in a lot of diseases, you prove what it is because you find something at autopsy. But with SIDS, it's not finding anything to explain the cause of death or clearly explain the cause of death that results in the diagnosis of SIDS. Okay, this is, I'm not going to show you this very long. These are also primarily theoretical because with all of these little factors that we saw, you can now theorize a triple risk model of a vulnerable infant, perhaps some developmental problem in your homeostatic control mechanism, brainstem anomalies, areas, cardiorespiratory control. It would be almost ridiculous to think that someday somebody's going to find a specific cause. If they did, it wouldn't be SIDS, right? So here we go. Here's the things that have happened and we're well aware of to prevent SIDS. One of them is to reduce their risk factors on the maternal side. More babies are avoid prone sleeping. They get harder mattresses. They generally don't put soft pillows and allow, prone sleeping. It's more supine sleeping. No excessive blankets. Better room control. Okay, no space heaters. These are all things that are well known to all mothers now, if they're concerned about that. And once again, diagnosis of exclusion, complete autopsy, no findings. It's a very big medical legal thing too, and very often, routinely, there is a very, very big death scene investigation. The parents who are already devastated more than they could ever possibly imagine in their entire life are now drilled by the police and given the subtle hint that maybe the police are thinking of either child abuse or intentional suffocation. So that has to be pretty much ruled out as well. Okay, this is a good time to stop because we only have one topic left, and it's going to be tumors, and it's not that big. So let's take our break, and I also want to tell you that if we have some time, we may look at a couple of these lab cases as well. Perhaps not all of them, depends on time, but tumors of kids is not really a big topic. We might look at some of the things that we talked about. And we're going to have a very nice and appropriate tribute to the major faiths, the major ways people worship God all over the world. And we'll start out with I asked one of my Islamic students to please give me the name of the most profoundly inspirational Islamic music. I asked the same thing to our Hindu friends, and I picked out the Christian one because that's what I am. So we'll see you in 10 minutes, folks.
Allah the Almighty. Allahu Allah. Protect me and guide me. Allahu Allah. Oh, to your love and mercy. Allahu Allah. Ya Allah, don't from beholding your beauty. Allahu Allah. Oh, my Lord, accept this plea. Allahu Allah. Hasbi Rabbi Jalla Allah. Allahu Allah. Ma fi qalbi ghayru Allah. Allahu Allah. Affeder günahı. Allahu Allah. Alemin padişahı. Allahu Allah. Yüreklerin fenahı. Allahu Allah. İşit Allah derdimi, bu ahlarımı. Rahmeyle bağışla günahlarımı. Hayreyle hem akşam hem sabahlarımı. Hasbi Rabbi Cennet-Allah. Allahu Allah. Ma fi kalbi gayrullah. Allahu Allah. वो तन्हा कौन है? अल्लाहु अल्लाह। बादशाह वो कौन है? अल्लाहु अल्लाह। मेहरबा वो कौन है? अल्लाहु अल्लाह। क्या ऊंची शान है? अल्लाहु अल्लाह। उसकी सब निशान है? अल्लाहु अल्लाह। सब दिलों की जान है? अल्लाहु अल्लाह। Hasbi Rabbi Cennet-Allah. Allahu Allah. Ma fi qalbi gayrullah. Allahu Allah. Ya Rabbal Alamin. Allahu Allah. صل على طه الأمين. الله الله. في كل وقت وحين. الله الله. املأ قلبي باليقين. الله الله. ثبتني على هذا الدين. الله الله. واغفر لي والمسلمين. الله الله. حسبي ربي جل الله. الله الله. ما في قلبي غير الله. الله الله. على الهادي صلى الله. الله الله. لا إله إلا الله. الله الله. حسبي ربي جل الله. الله الله. ما في قلبي غير الله.
कदम कदम पर मदद तुम्हारी ये एहसास दिलाती है। कदम कदम पर मदद तुम्हारी ये एहसास दिलाती है। सोचो तुमको कौन मिला है, सोचो तुमको कौन मिला है, कौन तुम्हारा कदम कदम पर मदद तुम्हारी ये एहसास दिलाती है। पल भर जब भी होते अकेले पास मेरे आ जाते हो। पल भर जब भी होते अकेले पास मेरे आ जाते हो। धीमे धीमे कानों में अनहद नाद सुनाते हो। एक किरण अनदेखी आती, एक किरण अनदेखी आती, राह दिखाकर जाती है। भरते हुए ना किसी ने देखा पर झोली भर जाती है। कदम कदम पर मदद तुम्हारी ये एहसास दिलाती है। एक बार कहा तुम मेरे हो, 100 बार तुम्हारा प्यार मिला। एक कदम चले तेरी राहों में तो जन्म जन्म का साथ मिला। ऐसी करुणा ऐसी ममता, ऐसी करुणा ऐसी ममता तेरी याद दिलाती है। प्यार में प्रभु के दिल खो जाता, आँख सजल हो जाती है। कदम कदम पर मदद तुम्हारी ये एहसास दिलाती है। सोचो तुमको कौन मिला है, सोचो तुमको कौन मिला है। कौन तुम्हारा साथी है। कदम कदम पर मदद तुम्हारी ये एहसास दिलाती है।
Wow. Some of that, some of the most beautiful music in the world is sacred religious music. I hear some of this stuff, even if it's not from my own religion, and it sends chills down my spine. And sometimes it makes you wonder whether the person who wrote that song or composed that song was being helped, perhaps, by the same entity that it was praising. Anyway, that's just a thought. I'm going to spare you the emotional speeches for the next session, which I know a lot of you will be at. I'm also going to encourage you once again to bring your microphones for our graduation day. Hope you all come. If somebody also asked me a question about Rock Lab, and we normally make the Rock Lab deadline by the last class, which would normally be in 2 days. Some people have turned it in already, but because the course normally extends until the end of May, and we ended early this year because of our increased sessions that we had when we were in Puerto Rico, we will say that absolutely no Rock Labs will be accepted in June. So you have till the end of May, and as soon as you finish your Rock Lab and you send it to me, I'll try to schedule all of our interviews or oral exams for the last day of May. That was the question. Last day of May is when we'll do our Rock Lab oral exams. Or if you rather call it an interview, and I guarantee you, if you do Rock Lab and they look pretty good, I don't think you have to worry or wonder about whether you're going to pass the oral exam or not. Okay, I guess we could start. No emotional speeches today. We'll save those for last graduation class in 47 hours when Dr. Mack is here and when Dr. Liu is here. Dr. Mack will also administer the Hippocratic Oath, which I believe in very, very much. Okay, pediatric tumors, tumors of childhood, cancers of childhood, benign and malignant tumors of childhood. Let's talk about the common ones, okay? Now, because we always divide tumors into benign and malignant, I guess you could say the first thing we'll talk about are the common benign tumors. And probably the most common benign tumor is a birthmark. Those are usually hemangiomas. That's why they're red, okay? And they're usually capillary hemangiomas, which means the blood vessels are very tiny. They're usually not much bigger than a capillary. The blood vessel tumors that have big spaces, the cavernous ones, those are mostly in adults. I always remember the smaller the hole, the younger the kid. Small holes, small humans. The lymphatic tumors, we talked about hygromas. If you want to think that everybody with hydrops that has a lot of neck edema might qualify for a lymphangioma, you could think that way. The thing that you'll notice is that most of the benign tumors in children are not benign tumors of epithelium. They're all connective tissue. Here's a hemangioma, that's blood vessel connective tissue. Here's a lymphatic tumor, that's another type of vessel benign tumor. Here's one tumor of fibrous tissue. So they're all basically connective tissue. They're benign. The fourth thing on the list here is something called a teratoma. And teratomas may have epithelial or glandular or any kind of element, but that's fourth on the list. The top three, none are epithelial. Okay, let's talk about without a doubt, the most common one. The thing you should remember is that not only do the blood vessel tumors are the most common benign tumors of kids. So in many cases they're called birthmarks. Sometimes they're given other names as well. The most common tumor of infancy, they're visible on the skin, more likely to be on the face and scalp than on the extremities, but they could be anywhere where there's skin. The thing is, the pediatricians are never ever too eager to remove these things, even if they're big and ugly, because in many cases they spontaneously regress. And here we go. Here's a kid with a big tumor of small blood vessels, Okay, this is a hemangioma. Do you see how you could clearly see red cells inside of very tiny blood vessels? These blood vessels are hardly bigger than the cells that surround them. That's why it's called a capillary hemangioma. Now, just as a contrast, I'm going to show you another one in an adult, but it's not a birthmark. This is the other type of hemangioma, the cavernous, and see how big those spaces are. The capillary congenital hemangiomas often, here's one, same kid, 2 years later, not much left, spontaneous regression. And I think this is a good time to talk about the concept of spontaneous regression because, you know, I always have people that ask me, you know, could cancer go away by itself? And of course, the answer is no. There have been some case reports, particularly with leukemias, lymphomas, melanomas, and especially medulloblastomas, which is a tumor in kids, which we're going to talk about, in which the tumors completely regress spontaneously without any treatment. Now, I want to tell you, when you look at these tumors and it's documented that they've gone away by themselves, it's more likely to be in a child, and it's more likely to be in a younger child. And here's a benign tumor that has spontaneously regressed, and I think that the general thinking for this with most pathologists is that, you know, what makes this goes away is the fact that the tissue matures rather than, you know, some magical force from the sky zaps it and makes it go away. Okay. And of course, if you have somebody in your family that has cancer and you know that there has been a possibility of spontaneous regression, that's the one thing you're always hoping for. But statistically speaking, that doesn't happen. I fell into that trick myself, but that's just being human rather than being a scientist or a doctor. Teratomas are also in childhood. If you remember, definition of a teratoma is that the cells of derivation are from more than one germ cell layer. Remember, the mesoderm gives rise to mesenchymal tumors or sarcomas or connective tissue tumors. The epithelial layers like ectoderm and endoderm give rise to more things like the carcinomas, like squamous cell carcinomas, like adenocarcinomas. Teratomas are derived from two of the three derms, and sometimes all three. In fact, usually all three. The most common place for a teratoma in a kid is in the sacrococcygeal area, tip of the spine. We don't know why, but it's the most common childhood teratoma. And even though it's the most common childhood teratoma, look at, we're talking about every 20 to 40,000 live births, and for some reason they're a lot more common in boys than girls. And about, oh well, it says 12, but let's make this simple. Let's about 10% are malignant. Yeah, they can occur in older children too. Here's something you really don't need a microscope to diagnose. This is probably a stillborn infant, and there's a big tumor that looks multi-cystic, yellow and red, and you can imagine if you cut through it, there's a lot of different types of tissues. That's a classical sacrococcygeal teratoma. Actually, I can't think of anything else this could be in that location at that stage of life. Let's talk about the solid tumors of childhood. Now, we know that the lymphomas and leukemias occur. The solid tumors, there's two big ones. There's the neuroblastomas, there's the Wilm tumors. They're basically in very young children, ages 2, 3, 4. And let's talk about them. See that? In age 0 to 4, we have neuroblastoma and retinoblastoma as being one of the top twos. The leukemias, which we've already talked about, are always at the top of the list, so you remember that. And the Wilms tumor is generally seen only in younger kids. I think about 2 years is about average. You don't normally see those, but the neuroblastomas you can still see. You can get soft tissue sarcomas, just like we said, most of the benign tumors are from connective tissue, well, the malignant tumors as well. We talked about teratomas, and remember brain tumors as well. So We talked about central nervous system tumors already for adults and children. We talked about neuroblastomas for adults. We talked about Ewing sarcoma, and we talked about lymphomas up the wazoo, Hodgkin's, non-Hodgkin's. So let's talk about the two solid tumors that are specific for young children. Now, you want to know something interesting? I know a lot of pathologists that make fun of the pediatric pathologists because they basically say, you know, if a young child, has a solid tumor, almost all of the time we could diagnose this as a small, round blue cell tumor. That's not a specific diagnosis. That refers to the types of cells within the tumor. So if a young child has a mass, a solid mass, and it's a lymphoma, it'll basically look like small, round blue cells. Neuroblastoma, small, round blue cells. Wilms tumor, largely small, round blue cells. Even some of the sarcomas, the rhabdomyosarcomas, remember we saw those in young girls? Small, round blue cell tumors. They're completely undifferentiated cells. They don't have much cytoplasm, and they're all small, round blue cells. So if you stick a needle into a baby that has a malignant tumor, most likely it's going to be small, round blue cells. No matter what we talk about, we'll be talking about neuroblastomas and Wilms tumors. Of course, you could stain those cells for various markers or immunohistochemistry or immunoperoxidase. You could do electron microscopy and look for little vesicles or other particles. You could do chromosomal analysis. A lot of these have predictable chromosomal abnormalities, but generally malignant, solid baby tumors are generally in that category of small, round blue cell tumors. And here's one of the big ones, neuroblastomas. Even though it's the most common solid, or second most common solid malignancy of childhood after the retinoblastoma, it's only about 650 cases a year in the United States. The cells of the neuroblastoma, of pediatric neuroblastoma, are derived from the same place the cells of the adult adrenal tumors, neuroblastomas, are, and that's neural crest, okay? So a neuroblastoma is about just as likely to arise from a sympathetic ganglia as it is an adrenal gland. These are both areas of neural crest origin. They also may be rich in catecholamines. And they do not occur familially, so they're regarded as sporadic, okay? Whereas the retinoblastoma basically runs very much in families. The average age for a neuroblastoma is about 2 years, we'll say. That's the median age, and it can go as high as about 4. But if you remember, after age 4, the neuroblastomas are rare, but the Wilms tumors generally occur a little bit later than the neuroblastomas. It's a small, round blue cell tumor, like they all are. I want you to keep I want you to keep 2 things in mind. It's a new term which we're going to introduce you to, and it's called neuropill. And when you see neuropill in a tumor, a neuroblastoma, and you look closely, it's composed of nerve fibers, actually, axons and dendrites. It's mostly unmyelinated, but we also told you in the other neuroblastomas that we saw, in the ENT chapter and in the adrenal chapter, the endocrine chapter, that all neuroblastomas form rosettes. And you've already been introduced to the concept of a rosette. Sometimes they're called Homer-Wright rosettes. And of course, most of them will stain positive for a protein called neuron-specific enolase. There are other reliable stains that you could do. If you do electron microscopy of the neuroblastomas, their neural crest, their adrenal medulla, okay? You can also find secretory granules of norepinephrine, okay? And because it's a malignant tumor, you have your usual features of malignancy. You may have a high mitotic rate. You may have very high vascularization. And remember, the ganglion cells that you see in the adrenal, which look like they're multinucleated or forming a cluster, if you have a neuroblastoma in which you have ganglion features, what is the one thing that you could conclude? Well, you can conclude that because this neuroblastoma, whoops, guess what? I made a typo there, didn't I? Because this neuroblastoma is trying to differentiate into more differentiable tissue, it's probably going to be a better prognosis than something that doesn't try to differentiate into ganglion cells. And there's a whole bunch of other predictors that the pathologists and oncologists could do, because you could basically put these patients on the basis of those other predictors into, you know, low and high or bad and good prognosis categories. Here's a neuroblastoma. It's classical. I want you to remember, or you probably remember already, that when you have a bunch of cells sitting around a table, like Knights of the Round Table, and you see sort of a cytoplasmic substance in the middle, these are classical rosettes. That's the best rosette right here. But when you look at them more, you say, well, that's probably part of a rosette there, and so is that. But do you see the part that looks kind of fibrillar? Well, don't just write that off as, you know, pink junk. If you actually do electron microscopy, you'll see that these are actually nerve fibers, unmyelinated axons, dendrites. And if you look at these cells, they'll probably stain positive for NSE, or neuron-specific enolase, because of their neural crest origin. And they also will have, if you do EM, perhaps neurosecretory granules like norepinephrine. In fact, most of these have norepinephrine, but for some reason, you know, unlike the pheochromocytoma, it doesn't usually result in hypertension. I'm going to show you this picture to show you another feature of not only malignant tumors, but especially endocrine tumors. All of these red lines, as you already know, not only the big things, but all the little things, it shows that this is very, very vascular. You know, this can also be expressed as vascularity on angiogram as well. They correlate very well. So the reason why about a third of the cross-section here is bright red is because this is a richly vascular tumor. Here's a neuroblastoma. Oh, perhaps you might have to use your imagination to probably think where are the rosettes, but you could see that some of these cells are forming what would look like ganglion cells. So that's a good prognostic feature, because we've seen time and time again during this whole course is that whenever a tumor cell tries to differentiate into the thing it was supposed to be in the first place, that's a sign of differentiation. In other words, better prognosis. So this is and because of this, this can now perhaps inherit the name ganglioneuroblastoma, because it's trying to form a ganglion. So here's our good news and the bad news. You know, the bad news is if that's been metastases, either lymphatic or hematogenic, if it's present in the lungs and bone, that's bad. We know that they all produce catecholamines, or most of them do, but they don't get hypertension. We know that if a younger person, we said that the median age was about 2 years, but generally the kids who get them under 2 years do better than the ones that are over 2 years, no matter what the stage is. So age is a true prognostic factor. And there's a gene that is amplified in this tumor. If you remember, we talked about N-mic. So when you have amplification of N-mic oncogene in this tumor, it's a bad prognosis. So if you add up all of these good and bad newses over here, and you wind up putting this baby in a low-risk category, my God, you know, it's 90% chance they'll be cured. If it's in the high risk, it's very, very unlikely to get a good permanent remission, or in other words, a cure. Let's talk about the other big solid tumor of childhood, the Wilms tumor. It is the most common primary renal tumor of childhood, but overall, the incidence, even though it's a most common renal tumor, the incidence of this in children under 15 years is usually like 10 per million. So the overall incidence is not that big. And whereas the neuroblastoma is usually 22 months is the average, that's usually the lower end of the spectrum for Wilms, so there's usually not too much of an overlap in there. A good number of them are multifocal or bilateral, okay? Now, you can use the term synchronous or metachronous when you think of multifocal. Synchronous means everything occurred at the same time. Meta, or after, means that you have seen one, and then after the appearance of one, perhaps even after treatment, you get the presence of another one. And the main reason, or the main thing that determines a prognosis, is the presence of little accessory nodules that you could find, you know, which we'll talk about. And those are called rests. So, clinical features: children with a large abdominal mass. It's no longer just something little in the kidney. The good news is, in the United States today, everything else being equal, I'm very happy to report it wasn't this way 20, 40 years ago. We have now about a 90% two-year survival rate, okay? Even if there's been spread beyond the kidney. Isn't that spectacular? That's another really good thing to report with the weenies, you know, besides other cancers like the acute lymphoblastic leukemias. We're going to talk about nephrogenic arrest, too. Now, we know that Wilms tumor, about 10% of the time, occurs in well-recognized congenital malformation syndromes. I wrote them down. I could probably talk about them for a little while, but I don't think so. One of them is called WAGR. Sometimes they put an O after it for obesity. But the Wilms tumor, aniridia, no iris, genitourinary malformations, even genitourinary tumors, and mental retardation is one syndrome. It's called WAGR. Okay, in this syndrome, you frequently get Wilms as well. There's another syndrome called Denny's-Drash, which is associated, is a known congenital malformation syndrome, also associated with Wilms, and there's another one. But 90% of them occur without these syndromes. And one of the key prognostic factors and observations is this concept of a nephrogenic rest. So, in other words, if you remove a Wilms tumor and you see something called a nephrogenic rest, which is present in almost half even of the unilateral tumors. I'm going to show you what a nephrogenic rest looks like. You see this upper part of the picture here? That's a glomerulus, that's tubules, that's normal kidney. But do you see this little nest, perhaps microscopic, of less differentiated tubular-like structures? That's a nephrogenic rest. So if you see nephrogenic rest, it's more likely that this is going to be bilateral, okay? And if you see somebody with bilateral tumors, 100% of those are going to have these nephrogenic rests. If you find a nephrogenic rest in one kidney, they are very much predictive of much higher increase of risk of tumor in the other kidney. Now all we got to do is show you the pathology. And just like with the neuroblastomas, we said you have to remember the concept of neuropil and rosette. With the Wilms tumor, even though they're both small blue cell tumors, you should remember three elements now. Okay, grossly, you could already see it in the side over here. It looks like a very hemorrhagic, necrotic, variable type tumor, fleshy, soft. Microscopically, we're going to be showing you three things. We're going to be showing you the small blue cells, the blastema, but you may also see elements of epithelium, not only tubules, but perhaps primitive glomeruli. Remember when we showed you the kidney of a very, very immature person? It didn't look like the glomeruli were quite fully developed. Well, you could see those in the tumor as well. And of course, you can see a lot of connective tissue, the stromal elements. So you're going to see blastema, epithelium, primitive tubules, and stroma. One of the poor prognostic features, other than the usual anaplasia or perhaps lack of more differentiated elements, is the fact that if this has a P53 mutation, which it often does, it's generally going to be a bad prognostic feature, perhaps resistant to chemotherapy. Here, let me ask you a question now, even though we may see this in lab. I don't know, maybe we will. Here's the question. What kind of Wilms tumor do you think would do better? Something that was 100% blastema, or something that was 50% tubules and glomeruli? Which one do you think would do better? That's the question. Yeah, of course, because the more a tumor tries to develop to where it's supposed to look like, the better it's going to be. Here's your three things. Okay, that the connective tissue or stroma is about 50% of this, and you can see that it's largely in the middle portion. These cells here, which just look like undifferentiated cells, these small blue cells, you know, on the H&E appearance alone, you could say, if you just took these cells out here and you show them to my pathology buddies, they would say, oh, maybe this is a lymphoma, maybe this is a neuroblastoma, you know, maybe this is a retinoblastoma. But when you show them this, the fact that the tumor has little tubules, like you see here, and perhaps little budding things that look like they're very primitive glomeruli, then it makes it an easy diagnosis, doesn't it? Here's the same thing again. Here's your three things. The blue arrows are your primitive glomeruli, as opposed, as you can see, to a perfectly normal, well-developed, multilobulated, multivasculated glomerulus. Most of these glomeruli look like they're just primitive buds. A lot of blastema. There's blastema. And I bet you if I look, I could probably convince you that some of these things look kind of tubular and not just like blastema, like perhaps over there. So here's the final test question. In fact, it's the final PowerPoint of the year as well. I'm going to put my pointer over three areas, and I want you to either say B for blastema, T for tubule, or S for stroma. Okay, here's the first thing. Okay, what about this thing? And what about this stuff over here? Yeah, you got them all right. Okay, we're done. Let me look at the clock. It's 10:41. You know what I'm thinking? I do have a little bit of a lab here. Some of these we've already seen. I don't want to get too choked up and emotional. I'll save that for Thursday. But what I'm going to do is I'm going to, at this point, the one thing that I have been very guilty about is not listening to you more. Okay? My wife said that my number one problem is I never listened, you know, especially to her. So I'm going to ask you, if you have any questions right now, either type them in or I'll look at your attendance here and see if you got a microphone and you raised your hand. Okay? I know I've been neglecting this very, very badly. I apologize. But I'm also going to look at to see if any of you have microphones. Now, I know you're all going to bring your microphones on Thursday, but let's see if somebody you might have brought them today as well. I'm going to pop open the attendance list and look for microphones. And if not, we'll just look at the typed questions. And if the chat questions, if there aren't many of those, we'll go to lab. So, okay, first question. When do we get our certificate of attendance? Oh, well, that's a good question. Okay, the answer is you will get your certificate of attendance when after graduation, and you email me to let me know how many of the online or offline sessions you've been to. If this winds up being the vast majority, then you get a certificate, just like last time. And you know, no, that's okay. You could do that anytime. The next question was lab. Well, if there aren't any more questions, we will look at a couple of lab cases. So let's do that, because I don't see any more questions in the question box, and I don't see any microphones out there, but I hope you please bring them. I'm going to make Dr. Lou and Dr. Mack bring their microphones So bring your microphones, plug them in, talk to me for graduation, say whatever you want to say. So we'll pop this guy back in. We will go to lab, our last lab. I know you enjoy lab more than you enjoy lectures. Here's our slides. We just have a few of them. And they're, so I guess they're it looks like they're alphabetical. Oh yeah, they're alphabetical. I'll get rid of some of my icons here, which will just take a second. And you walk down the hall, you open up the door, you smell the formalin fumes, you put your key into your drawer, and you can see the microscope hasn't been stolen. The bulb is not broken, the slides are not broken or stolen. You're now setting up your microphone, you're plugging it in, you're adjusting your eyepieces, and you put the slide, which you see here, under the microscope, and you call over your lab instructor after he's done talking to the cute girls, which might never happen. And you see something here you could recognize as lung, and it maybe looks like congested lung or perhaps inflammatory cells in the lung. But at least in this area here in the northwest and most of the north and most of the southeast and most of the southwest, you can see there's still basically an alveolar or pulmonary framework. But in the middle, you see a very much of an increase in cells. And I think you would agree that in this middle area here, the alveolar or normal histologic framework is destroyed. And you know this is the chapter on babies. So you know this is a pneumonia. You probably can guess this is an abscess. And then you think, well, why would a baby have an abscess? And as you look further, you be a real good student. You don't just take somebody's word for it. You look around, you can see there's a destructive process going on in here. And we're going to move around even more. And I hope we could find it. I know we found it last time. So let's see if we could find it again. Oh, I hope we could find it. Ah. Well, maybe I'm just not lucky. But you know I'm looking for the kind of things that might cause an abscess in a newborn lung, like maybe they've aspirated. And of course, the most likely thing that they may have aspirated is this material here. This could be a residual of material. And so let's zoom that up, because it doesn't just look like regular inflammatory junk or fibrin, but it looks like it has sort of a squamous configuration to it. You know, this is not just pus, this is not just fibrin. These look like squamous cells, don't they? So you know that the aspiration pneumonia in this newborn was due to the aspiration of something that contains squames. Now, do you know what contains squames? Amniotic fluid contains squames, doesn't it? Don't they coat the surface of amniotic fluid? Can't they float around? So this is aspiration pneumonia with abscess formation secondary to amniotic fluid aspiration, you know, which is common. It's common for the kids to get a little bit of that amniotic fluid in their lungs if they decide to breathe before they come out, right? Okay. And you see the little squamous cells here. Let's move on. Oh, you're going to like this. You probably already saw the label to this slide, but I'm going to make you work on this one. You already know that this is kidney on the right because you see a lot of little glomeruli. You already know the kidney is totally inflamed with inflammatory cells. And you're probably wondering what the heck this thing is here in the left and in the west and in the south. And you all know that this is liver. You can see a portal vein over there. You can see the sinusoids are infiltrated with small cells. And you're probably thinking, oh, is this extramedullary hematopoiesis? Well, from this power, very much looks like that liver we saw, but remember, we got a kidney that is inflamed significantly, as well as a liver. So I looked at this last night, and I think you'll have to, if you were entertaining the theory that this is inflammatory, then you could see there's even more of an inflammatory process going on in the kidney. So we're talking about something that infects everything. And when you think of something that infects everything in a newborn, remember we said part of torch infection, one of the most common things is CMV. Do you also remember that we said of the 3 common viruses in the herpes family, the 2 that have the name herpes in them, like herpes simplex and herpes zoster, will show you eosinophilic intranuclear inclusions, but CMV shows you basophilic intranuclear inclusions. So not only is this kidney widely inflamed, infected, so is the liver. Take a look at these beautiful basophilic intranuclear inclusions. I'll tell you, most of my buddies would get this as being a CMV, like in the first, 2 seconds after looking at it. And this is really one of the best examples you'll see of, here's the rule. Infected tissue, CMV, like the others, herpes virus, ubiquitous, it infects a whole wide variety of, brain, liver, lung, everything. When you see an infected inflammatory organ and a few good examples of basophilic intranuclear inclusions, it's probably herpes until proven otherwise, because I really can't think of anything else. Somebody said, what's the mechanism of basophilic when they're a CMV? I don't know any more than I know. I know they're not viral particles, okay? They're too big to be viral particles. It's just the way the virus, reacts with the cell. And for some reason, in the other 2 herpes, it tends to be redder, and that's assuming that this tissue is stained properly. If the tech had a party the previous night and she fell asleep during the eosinophil part of the staining, they might look like they're eosinophil rather than basophil, even though most of them are stained automatically now. Okay, let's take a look at the next one. Remember in the last one we saw liver and we saw kidney and there was a basophilic. Now look, I think you'll agree pretty quickly that this is liver again. Some of the big circles are part of the portal vein, also have ducts around them and arteries. Perhaps some of these really smaller ones that don't have any connective tissue, maybe those are central veins. And let's take a look at the general middle area. There's a big portal tract. This looks like a central vein. But you see a peppering. You don't see cirrhosis. You see there's no increase in fibrous tissue. It's nice and limited. But you do see a peppering of cells. And in all honesty, these cells look like they have relatively small nuclei. And if you looked carefully, more carefully, you might find a couple of megakaryocytes. Oh, we might be able to find one now if I could convince you. When you see a cell that's about 6 times bigger than all those little ones, whenever you see a cell like that peppered with other small cells, this is extramedullary hematopoiesis. But the problem is, these are not just your normal display of hematopoietic cells. These are chiefly erythroid precursors, because this patient has a hemolytic anemia. There's a persistence and a preponderance of erythroid hyperplasia, not only in the marrow, but also in the liver. Oh, here's a megakaryocyte. See that? You want me to prove it by going higher, and hopefully it won't pixelate? Okay, there you go. Now, when you see a megakaryocyte with all these other cells, you don't have to wonder whether this is a hepatitis of CMV or whether it's extramedullary. You see that? Okay, here's the question. I'll make this an easy one. Do you see this cell here, and especially this cell? Are these megakaryocytes? Come on, you've seen them. You've seen a few. Okay, good. So we got our diagnosis. This is probably from a baby that was born dead from a hemolytic disease of the newborn. Here's another slide in our collection here. We'll make this quick. You can see it's a lung. You can see there's part of a bronchus. You don't see much cartilage around it. There's another lung. Looks like there's some junk inside of it, inflammatory junk. But the chief inflammatory reaction is basically throughout the lungs. You can see most of these alveoli here are filled with inflammatory cells. And even though that's one part of it, if I was to ask you, are the septum so thick in many cases you can't see them? And in addition, you have all these giant cells that don't look like they're part of granulomas, but they still look like multinucleated giant cells. Now remember, every time we saw a multinucleated giant cell, we'd say, oh, it's probably a histiocyte, or I'm sorry, a macrophage. I use the real term rather than the pathologist term. And this is what measles pneumonia can do. Remember, we're dealing with babies. This is a childhood. Most of the kids with measles that had severe measles and died, they died of pneumonia, and this is classically what their lungs would look like. There's a viral pneumonia, multinucleated giant cells, young kid, measles until proven otherwise. Even though we don't really have measles anymore, you may never see a case in your life. Here's another slide. And you can see that there's something. There looks like some kind of mucosa here, so let's look at it. I know you're going to figure this one out. Oh yeah, there looks like a mucosa. You can see goblet cells. They secrete mucin. Then you can see a submucosa with a lot of blood vessels. Then you see a circular and longitudinal and some prominent vessels there in the serosa as well. You know that this is GI tract. You know it's colon because these look like they're pits rather than villi. And you can see that the material surrounding them is very, very inspissated. This is a meconium plug. So the mucin that should normally, loosen this up now has resulted in a hyperviscidosis of the mucin. So not every kid with a meconium plug is cystic fibrosis, but this baby was. Just to demonstrate the viscousness of the mucus viscidosis, okay? Let's move on. Oh, you'll like this one too. If I told you this was a normal pancreas, you wouldn't believe me. You would say there's too much fibrous tissue there, and I can see a lot of junk obstructing the ducts, and I can see a lot of fibrosis and a lot of cystic dilatation of the ducts. If I told you this was a newborn or a young child died, or even an older child, you'd say, well, the pancreas is fibrotic and it's cystic. And I bet you could probably find a couple of normal islet cells here. You know this is cystic fibrosis. Okay, there's the cysts. The rest of this is fibrosis. Remember in the normal pancreas we didn't see any? And by the way, folks, what is this over here? Just to keep you honest. It doesn't really look like it's exocrine glandular, and maybe here too. Yeah, that's an islet. I could probably find you a better one if you don't believe me. Oh yeah, there's a nice one over there too. And look at, there's a nice islet too. Are the islets more common in the tail or the head of the pancreas? Without a doubt. Do you remember that one? Yeah, in the tail. Okay, good. Let's look at the next case. Oh, this will be the easiest one in the world. I think you could tell it's a lung. I could think you could see that most of those spongy spaces are collapsed. Maybe a few of them are even dilatated, but basically it's an atelectatic lung. You can see some blood vessels. Maybe we could find some bronchi. You can see there's a little bronchial lining. In fact, let's look at it. just to show you its lung. Okay, bronchial epithelium, collapsed lung, maybe edge of a blood vessel. Let's move on a little bit further, and you can see it's basically a lung that is not collapsed, but in the parts that are expanded or even hyper expanded, the one thing that you notice right away is that they seem to have a coating of pink hyaline eosinophilic material, maybe dead cells, maybe fibrin. This is respiratory distress syndrome. Okay, this is hyaline membrane disease. Okay? And these are the hyaline membranes, and they're all over the place. And I guarantee you that even if we did a random look, because I looked at this a little bit earlier, even if you did like a random look anywhere, look here, why doesn't somebody pick a random state of the union? You know, let's pick Illinois, because that's where I'm from. So Illinois is about here. Look at hyaline membranes all over the place. So hyaline membranes describes the pathology. Respiratory distress probably describes more the pathophysiology. I like it when there are two names for a disease, but when you put them together, remember both of them, they make more sense. Last case, probably be real easy as well. I don't know if somebody wants to blurt it out right away. We've seen this before in the chapter on female diseases. And we could see here, this looks like it's some type of tubular structure. It looks like it has sort of a papillary mucosa. There's blood inside of it. And then there's things here, which if you were good students and went to your embryology lab, you would see what looks like perhaps neural tube structures, mesenchyme. So what would a fetal-like substance be doing inside of a dilated tubular structure in which you could see immature placental villi as well? Look how similar they are. This is the papillary mucosa of the fallopian tube. These are the villi, okay? The syntrophoblasts, the cytotrophoblast. There's the amniotic membrane, and there's the baby, all in the same microscopic field. This is an ectopic pregnancy. Which trimester is this most likely from? First, second, or third? And you're all getting it right. So that's the end. We're done for today. I'm not going to say anything more. I don't want to get choked up. I'm going to have to now do the difficult task of trying to get a life until we start up again in August, in which we'll be doing stuff with some medical schools as well. The experiment we did with Puerto Rico, we're going to try it again and even make it better. And we're done for today. It's also 11:02, so it looks like we should play our final song. And I'm glad I didn't delete the box here, because I accidentally deleted our final song. So let's see if we could resurrect that final thing here. It's also going to be kind of a spiritual song, but it's also a very popular song by Josh Groban. And what I have noticed about this song and some of the spiritual stuff that we played, and I'll say it as my final comment, is that sometimes in your life you realize that you could do better, more spectacular things that you're not even humanly capable of. And I agree with that. And if you want to be not only as good as you could be, but better, I think you should connect with the source that raises you up. See you in 46 hours, you buzzards.
can be. Then I am still and wait here in the silence until you come and sit a while with me. You raise me up so I can stand on mountains. You raise me up to walk on stormy seas. I am strong when I am on your shoulders. You raise me up to more than I can be. You raise me up so I can stand on mountains. You raise me up to walk on stormy seas. I am strong when I am on your shoulders. You raise me up to more than I can be. You raise me up so I can stand on mountains. You raise me up to walk on stormy seas. I am strong when I am on your shoulders. Raise me up more than I can be. You raise me up so I can stand on mountains. You raise me up to walk on stormy seas. I am strong when I am on your shoulders. You raise me up to more than I can be. You raise me up to more than I can be.
Rock on, you buzzards.